Do you have SIBO and want to learn how to help yourself? The SIBO Success Plan is now available from thesibodoctor.com. In this highly anticipated plan, you'll learn my tried and proven method to treat SIBO, including home treatments, online dispensary guides, diet handouts, and much, much more. Already being treated by a practitioner? No problem. The SIBO Success Plan is designed as a standalone program or to work under the care of a practitioner. Become a SIBO-savvy patient and beat SIBO for good. For more info, go to www.thesibodoctor.com. Welcome back to part 2 of the SIBO Doctor podcast, and let's jump right back into it. Moving to the FMT arena, because I am a specialist in sort of chronic functional digestive disorders, IBS, SIBO, and many of my patients have, they ask me about FMT. Would this be right for me? Is this the best path to take to regrow my microbiome? And I thought we'd start off by just talking to people. I mean, it's a podcast for practitioners, but many patients, many thousands of patients are always listening, looking for answers. So maybe we do some myth busting first in terms of what is FMT, what is it currently used for, and your experience with it moving into that more deeper topic.
So fecal transplantation is something which was really popularized, not only in this country, but worldwide by Tom Bogaerde. And he wrote a paper in the 80s where he looked at 6 ulcerative colitis patients and did fecal transplantation into these patients. I'll speak a little bit technically about that now. And he basically introduced his paper by saying, we know that it works for Clostridium difficile, and conceptually that's very easy to understand. So Clostridium difficile Clostridia are microbiome. Clostridium difficile is a certain species. If you take antibiotics, then this species can overgrow and dominate your microbiome, and it produces a toxin which can make people very, very ill and give them terrible inflammation of their bowels and can in fact kill them. It's a very important disease in elderly people who've had antibiotic treatment, and it can be treated really by antibiotics, but antibiotics fail in a large percentage of these patients. Once you've had antibiotic failure, the only way to treat this is by infusing prepared healthy fecal donor material into patients. The best and the first proof of concept study really was a Dutch study, and they took stool from healthy donors, mashed it up, mixed it with a bit of saline, put it through a sieve, and then infused the stool nasojejunally. So that's a thin tube placed through the nose into the small bowel, and then this material was injected into the small bowel. We subsequently, or us as practical gastroenterologists, we've done the same sort of process, but we do it by a colonoscope. So you prepare a patient's bowel, you do a colonoscope, so you put the colonoscope all the way up the bowel. We try and get the colonoscope into the small bowel, into the terminal ileum, which is almost always possible. And then we have syringes of this material. The colonoscope has a channel, and we inject 2 or 3 syringes of about 50 to 60 mils, which is then injected into the small bowel. That then is a donor healthy stool, and that then proliferates and it suppresses the bad bugs. So conceptually, that's really how fecal transplantation got off the ground, and it's easy to understand. You've got a bad bug dominating, you take good bugs, you inject the good bugs either from the top or from the bottom, and the bad bugs get pushed out by the good bugs. That proof of concept was then extended by Professor Bogaerde to ulcerative colitis. We did the proof of concept study, which was published in The Lancet, and what essentially from a practical perspective was done is we took stool samples from multiple donors. The donors had been stringently tested for bad things. So you don't want to obviously have a donor that has Clostridium difficile, that has got, nasty things like Salmonella and Shigella in their stool. So you do lots and lots of tests. You do blood tests as well. You wouldn't, for instance, use an HIV patient's tests. So you make sure that the patient doesn't have, or the donor doesn't have infective diseases. And then you prepare that stool. It's a simple form of preparation. You sort of mash it up. You mix it with saline. You put it through a sieve. We used multi-donors, so 4 or 5 donors per sample. And the reason we did that is that we had to make sure that these were active donors, because some stool doesn't work, and we don't know why it doesn't work. We don't know how to know that the stool works. But by using multi-donors, we made the odds better that the stool would work. And there's some good data from a Canadian group that proved that. And then we injected it first by colonoscope, as I mentioned, into the ileum. But we also gave patients enemas to take home, which they did over an 8-week period, 5 days a week, from a frozen enema that they defrosted. They put it in their freezers, defrosted it, and then put the enemas into their bowels. It sounds pretty brutal, but remember, patients with ulcerative colitis often use enemas and suppositories to control their disease, and they accept it. Almost all patients are very, very happy to accept this because they know it works, and it actually indeed did work in a substantial percentage of patients. Some patients didn't do well with a fecal transplant, but other patients miraculously recovered. Now, there's a third way of giving fecal material to patients, which is perhaps the most acceptable. There's less work done on this, but it has entered the public domain, and there has been quite some good studies done on it. And that is to take the fecal material, to prepare it in the same way, and to dispense it into little capsules. The capsules are resistant to the upper abdominal digestion, so they go and release then the fecal material into the small bowel and the colon. The pun for this, or the easy to remember name for these capsules full of fecal material, is crapsules, and it's become an accepted term. So that's the third way of giving the fecal material. So to sum up, you can do it by a tube going through the nose. You can do it by a colonoscope or an enema going anally. And then you can also, probably the easiest way of doing it is by taking these crapsules. The disadvantage of the crapsules is that whereas if I do a colonoscope on a patient, I can inject 200 mils of excellent fresh material into the ileum, and that is a fantastic way of doing it. It's a transplant, so you transplant the fecal material right into the place where it's active. You can use fresh fecal material. You can actually get a really, really good result because you get a very high volume of the bacteria in the right place. The crapsules, perhaps the dosage is not as good. They would always be frozen samples, so you freeze them at -80 and then give them to the patient once it's been defrosted. But certainly that is a cool way of doing it, and you can do it on a daily basis. Some good data to support it, but there's always advantages and disadvantages of the different techniques. For me, the technique which is perhaps the most challenging is the nasojejunal technique, as performed by the Dutch group. So we don't really do much of that.
So, because this is a SIBO podcast and a lot of people are suffering from SIBO, of course they're going to wonder why we're talking about FMT when it doesn't really pertain to SIBO, which is, of course, a condition where bacteria are overgrown in the small intestine. And so my first question to you is, why are you putting it into the terminal ileum? Why not just into the colon? Is there a reason why? I mean, obviously there's a reason because you're doing it that way.
Well, yes, that is a good question. So the reason, so it's sort of a gradient. We do get effects if we put it into the rectum and the sigmoid colon, because we see the effects if we use enema preparations. The thinking behind putting it into the terminal ileum is that we want to keep it in the bowel as long as possible. So if we can put it as deep as possible, it sort of stays in the bowel, and the terminal ileum, we suspect, will then feed it into the colon in a slightly sort of slower and more controlled way. We also give patients buscopan, which sort of stops the bowel motility, because once we've injected this very valuable material into the bowel, we want to keep it there as long as possible. The only reason we put it in the terminal ileum is because we think it'll then stay in the bowel a bit longer. But the terminal ileum is right by the colon, so we want it to stick around in the terminal ileum for a little bit and then be sort of milked into the cecum, where it can start growing and reproducing and displacing the bad bugs. So that's the only reason. There's no genuine science behind that, I'm afraid.
Okay. Well, and the reason really why we're talking about it is because so many people have more than just one issue when it comes to SIBO. They have multiple microbiome dysfunction issues that this question often comes up. So, and typically when the motility is functioning correctly, you can inject the FMT into the ileum or even up into the jejunum, and motility should just sweep it down. So I think I had another conversation with Dr. Mark Davis, who is in America doing these, teaching people how to do home treatments of FMT. Yeah. So, we had that conversation. So the other question I had was more, because you were actually mentioning just now how fecal material actually is, well, you didn't say it, but I'm pretty sure it's mostly dead bacteria, and maybe the more immunologically active bacteria are more in the mucosa. So are there some methods to siphon up mucosal sort of aspirates?
No, well, I think your fecal material in your bowel is mostly alive. But when it leaves the bowel, it's because it's an anaerobic organism, so that means oxygen is toxic to them. When they leave your bowel and they hit oxygen, there's a very clear data that they start dying. So oxygen is poison to these organisms. That's why culture of them is so difficult. So yes, indeed, once you've passed your stool, your microbiome external to your body will very soon die. But when it's in your body, it's pretty robust and on the go. Can you access somehow the mucosal organisms? Absolutely not. They stuck quite tight to that mucosa, and they're a very small population. But I think they're an important population. So I think even though they make up a tiny percentage of the microbiome, they are perhaps the most important one, because they are the ones that interact very closely with your body cells. So if there's anything wrong with your body, if there's any leakage, if there's any immunological overexpression or problem, these are the organisms that are very close to the immune active cells. And no doubt they play a more important role in Crohn's disease and ulcerative colitis than the organisms which are further away.
So I've had a number of patients who came to me post FMT and who really did not improve at all for various reasons. And of course, I don't see the thousands that have been helped by FMT because they don't come and see me. But one of the issues was, I don't know if you do this as well, but certainly Dr. Bogaerde, I think, is still doing this with the 3 months vancomycin. The prep work to actually get an FMT, according to his protocol, included many months of vancomycin and I think recently also rifaximin. And then after that time period, you receive your FMT, which, I understand you want to kill as much as possible of pathogenic organisms before you implant a pristine sort of microbiome. But I just wondered if anything had changed, because many people that I see that for which FMT did not work really suffered quite a lot with those many months of antibiotics, where even their bladder started to, other mucosal surfaces really started to show signs of antibiotic overuse.
Well, I think so. Firstly, that's quite a difficult question for many reasons. The first reason is we don't know. I certainly don't know. The second important point is that Professor Bogaerde is the world expert, and I certainly am a tiny speck in his shadow. So I would be very hesitant to disagree with Professor Bogaerde, except in the most polite and humble way. So the fact that Tom Bogaerde is doing that is compelling evidence that that's how it should be done. I am, however, someone who's very concerned about antibiotics, and I am a little bit frightened of using antibiotics, and I certainly am frightened of using long-term antibiotics. So I'm sort of an anti-antibiotic guy, so to speak. But also, so for me it's difficult because I'm a pro-Tom Bogaerde guy and an anti-antibiotic guy, so I'm sort of in between.
Yeah, that's got to be a tough place.
It is a tough place to be, and certainly, one wouldn't. I find in the modern world, I often get patients who are anti-expert, and I think with the growth of the internet and social media and accessibility to things, and the sort of feeling that experts are part of this sort of elitist clique, and certainly experts do get it wrong a lot of times. But I'm very hesitant to go against the opinion of a world expert. But I am a little bit uncomfortable with long-term antibiotic use. I think antibiotics are, I said it in my talk, and it was sort of somewhat tongue-in-cheek, but they certainly are agents of the devil as far as patients are concerned. We have to be very, very careful with antibiotics. Antibiotics save lives, we know that, but they have very quick and rather dramatic effects on very important organisms in our body. There was a recent study that came out, which was a small study, which emphasizes this point. It was a study looking at 28 patients in an ICU setting. And the study set out to look at their microbiome just as they went into ICU. It looked at their microbial diversity. And then almost all patients in ICU obviously are very sick, and they get antibiotics and things. And they looked at their microbial diversity 3 days after treatment. And within 3 days, these patients had totally lost their microbial diversity, and they had a terrible microbiome, which is associated with A, being in ICU, and B, getting antibiotics. But what was more scary is that 3 patients next to each other were almost exclusively colonized by an Enterobacter which is quite a dangerous species. So obviously, just being in ICU, and it's an ICU where people follow protocols and wash their hands and use gloves, but this organism obviously infected one of our patients, or those patients, and then spread immediately to the contiguous patients. So what's happening in patients who are unwell and receiving antibiotics, we get an almost immediate destruction of their natural microbiome, and that this microbiome destruction can be transmitted between patients in the hospital setting. That's now been shown. So it is a little bit worrying. But I really think antibiotics, the most important assault on our microbiome, I think, is obviously antibiotics. And the second most important assault is the terrible stuff we put in our diet, the processed food, definitely the lack of good roughage and the lack of healthy food like the Africans eat, the rural Africans, certainly not the urban Africans. And then the dreadful chemicals such as emulsifiers, and even worse than emulsifiers are artificial sugars. These things completely destroy your microbiome and have a terrible effect. One of the most important things I try and teach my patients is never use artificial sugar. I had a conversation with a patient the other day, and he said he drinks lots of Diet Coke. It was quite a fit-looking guy. I said, well, Diet Coke is terrible for you, so rather drink ordinary Coke, which is horrible.
I can't believe you told him to do that.
Well, but it's the truth.
I understand the reasoning.
If you can choose, and this is an extraordinarily important point. If you can choose between drinking Diet Coke or ordinary Coke, you've got to be, I personally I can remember very clearly the last time I had an ordinary Coke. It was 34 years ago with my mother in the game reserve. So that's the last
a long
time I
time
had a
ago.
Coke.
Well, the last time I ever recommended anyone to drink a Coke was never.
Well, exactly. So that's the right advice. Never drink Coke, but never ever drink
Diet
Diet
Coke.
Cool,
Yeah.
because the artificial sugar ferments in your colon. It doesn't get absorbed, and it has got very bad effects on your microbiome. So, and in fact, artificial sugars, so they grew out of this perception that people were getting fat, which they were, and the solution to fatness was to take away sugar. Sugar definitely makes you fat, but it does appear that artificial sugar makes fatty liver disease, and it actually drives obesity and insulin resistance via the microbiome. So yes, never drink Coke, but never drink Diet Coke.
Never drink Diet Coke. And not to mention pesticides and glyphosate and all these other chemicals that certainly impact the microbiome. So moving back into the FMT space, I wondered if, we know that C. difficile and now more recently ulcerative colitis are more accepted conditions for which FMT is indicated. But what do you see on the horizon for conditions like depression or anxiety and sort of also neurological issues, perhaps like Parkinson's or Alzheimer's? So are there any indications for those kinds of conditions with FMT?
Yes, there are. And have we got 12 hours now to chat?
We've got 10 minutes, Johan.
Do you want to see your family tonight? So, before I answer that question, I'm just going to say that our microbiome produces and controls neurotransmitter substances. We all know about serotonin, but adrenaline, noradrenaline, your neurotransmitter substances, your gut is incredibly important in how these are made, produced, metabolized. There's been a recent paper in Nature, which was an extraordinary paper. What it did is it looked at serotonin, and it showed, we know that a germ-free mouse has a certain level of serotonin. If you introduce a microbiome to those germ-free mice, the serotonin level goes up 90%. So it's got it does this through decoupling and various other mechanisms. But the recent study, which was an extremely difficult study to understand, because Nature studies are just written in a special way that makes your head ache. But in essence, what this paper said was that the serotonin, not only do our gut organisms act and change serotonin levels, but the serotonin levels that we produce in our gut and in our body makes these organisms grow and grow better. These organisms have evolved a receptor which is very similar to the human serotonin receptor. So just think about that. So we've co-evolved with bacteria, which we split from billions of years ago. So when multicellular organisms split from unicellular organisms, which happened about 1 billion years ago, that's how far away evolutionarily we are from these organisms, probably further away. And these organisms that grow in our gut have developed a receptor which works on human serotonin. If human serotonin is given to them, it seems to feed them and make them grow bountifully. And even more important, if we give these human people Prozac, which binds the serotonin receptor, these organisms grow less well. So the Prozac inhibits their receptor, which makes them grow. So how amazing is that? That one, the organisms contribute to serotonin. Two, serotonin contributes to the organism. And three, If we give our patients serotonin-type medication, that messes the organisms up as well. So it's an incredibly complex interplay of events. There definitely is evidence that Prevotella is absent in patients with autism. There's been a very good recent study where giving patients Prevotella and giving them a fecal transplant improves autism. There's very good evidence that synuclein is a protein involved in Parkinsonism. We find that protein in the gut, and the microbiome plays a role in production and distribution of that protein from the gut to the brain. We know how that happens. We know that the vagus nerve, which connects the gut to the brain, appears to transport this protein into the brain, where it can be important in producing Parkinson's. We know that if we take a biopsy of the bowel and stain it and look at it in a special way, it can predict Parkinsonism down the line. So just think about that statement. You, as an endoscopist, I can look into someone's bowel, take a bit of tissue, and then I can say, well, wow, you're heading towards Parkinsonism. I can't do it yet, but certain people in an experimental lab can do that. So
is that something that's going to, I can see so much use for that. One of the very early symptoms of Parkinson's obviously is constipation. So,
absolutely.
And in this tissue. So that sounds really exciting, because it's such a debilitating disease that could potentially be prevented once you discover it early on.
So one of the things I also do, which is not microbiome related, is I put in jejunal tubes into the small bowel of patients, and we infuse duodopa, which is a pure dopa type product. We know that Parkinson's is caused by dopamine deficiency. And you literally see patients with end-stage Parkinsonism getting up from their beds and walking away. It's like,
wow.
It's a Lazarus thing. So by infusing dopamine into the gut, we can change how these people function instantly. It's an absolutely miraculous process. But we know that the gut also produces dopamine. Dopamine is an incredibly important immunomodulator in the gut.
And GABA and noradrenaline and so many different, it is a super exciting field. So would you say, somebody's listening to this and saying, wow, I've had so many antibiotics. I have, for example, the kind of demographic that I see besides chronic SIBO is extreme sensitivity because of certain species loss, like Oxalobacter formigenes, for example, and all of a sudden you can't really break down oxalates or salicylates, and histamine is a huge one. And so this question arises a lot more with functional digestive disorders rather than these more really invasive and inflammatory conditions. Do you see a future role for FMT for those conditions where we could potentially replace microbiome aspects for patients to just metabolize normal foodstuffs a bit better?
Before I answer that question, which is, once again, if I really answer that question, you're not going to see your family for a week. So I'm going to answer it in a very brief way. Just to tell our audience, what does functional bowel disease mean? Functional bowel disease, in essence, is things like irritable bowel, but you get functional disease of the gallbladder, the bile duct, the upper gastrointestinal tract. Functional simply means that the gut is symptomatic. Something is wrong with the gut. These patients are highly symptomatic and debilitated, but we can't find an organic template to explain this. So they come in with symptoms which could fit in with cancer: extreme debilitation, abdominal pain. You look in the colon and there's nothing there. So the function of the colon and the way the colon interacts in the brain-gut axis is disturbed. Now, nothing that we do to treat functional bowel disease really works. Why do I say that? And there's been very good studies looking at lots and lots of patients. There was one study looking at many patients over 10 years with functional bowel disease, a tightly controlled study. These patients received the top-of-the-range type treatment. At the end of 10 years, 91% of those optimally treated patients had exactly the same symptoms. So whatever we're doing for functional bowel disease, it ain't really working. But I think we need to accept that functional bowel disease is a disturbance of the brain-gut axis. It sounds sort of almost ludicrously obvious, but I think it is. So it's a disturbance of the brain talking to the gut and the gut talking to the brain. And it's a disturbance of how the gut contracts, how the gut reacts to immune stimuli, how the gut reacts to organisms and food and stressful situations. So it's not even a bidirectional flow. It's a multi-directional flow between the gut, the immune system, the hormonal system, and the brain. How can we positively influence that system? The only way to do it clearly is to dramatically change and address these patients' microbiome. What are the hurdles to doing this? It's very complicated. The main hurdle to doing this is we don't understand how it works. We don't understand what microbiota are important. We don't understand what the mechanism is. We can't isolate the correct organisms and give those to the patients. And importantly, organisms that we give to patients often don't take. So you've got a robust bunch of organisms growing in your gut. I pump in, foreign organisms. These organisms aren't going to grow well because there's a resident population. And that's clearly why experts like Professor Bogaerde try and reduce the viability of the resident population. How the complexity of this is obviously mind-blowing, because you've got not only all the organs, the brain, the adrenal glands, the gut, the immune system working against each other or with each other or in concert, but then you've got the multiple different types of organisms. You've got the candida, you've got the archaea, you've got the bacteria, you've got the viruses. So to put this all together is going to be unbelievably difficult. The other major problem with functional bowel disease is that it's really difficult to define. We don't know how to define it. We've got these criteria, which I think are junk. If you look at the Rome criteria for functional bowel disease, I just don't think it's that helpful. I think it doesn't categorize patients carefully into different sort of groups, and it's for me it's a very difficult. It doesn't really help me. It's too broad. It's too non-specific. I agree. Do you agree?
Yeah, I absolutely agree. And a lot of patients don't fit any sort of criteria, and those are the demographic that I see that sort of defy any sort of or definable diagnosis. These are just combinations of issues that are going on for them that really need a multi-layered approach, has been my experience. And I'm glad you mentioned the gut-brain axis, because many people who are very, very dysregulated benefit greatly from therapies like neural retraining or gut-centered hypnotherapy, or the myriad of therapies that really aim to almost reset the brain rather than focus on target organs.
Absolutely, and Professor Cam, who's my mentor, he even in all his patients, in inflammatory bowel disease, functional bowel disease, he's the expert in this. He's always worked with a team of psychologists and psychiatrists, and he focuses incredibly intensely on the psychological and the psychiatric aspects of gut disease. And he's been doing this for 20 or 30 years. Now we sort of may find a link and a bridge between the gut and the brain, which we think is the microbiome. I think Professor Cam agrees. But to see these diseases, if a patient comes in and says, I've got irritable bowel syndrome, IBS, I think it's hundreds of diseases. It's got hundreds of different etiologies. There's not going to be one approach that's going to work. It's got to be absolutely tailored to the patient. And And there's a very powerful, the problem with the research in functional bowel disease is there's a massive placebo effect. So, as doctors, is it wrong to use the placebo effect? I don't think it's wrong. I think if you can, and I think a lot of the cognitive treatment is speaking to patients, making them understand that they have got a difficult disease and teaching them how to live with it, managing the disease. But although the evidence isn't overwhelming and the meta-analyses that have been done don't really support at this stage microbiome manipulation in treatment of functional bowel disease, I am sure that is where the action is. I'm sure that's where it's at. I think it's more complicated than it looks, and it looks bloody complicated in any case. But I think that's where the action will be. That's where the breakthroughs will be. Is it going to be like nuclear fusion? That nuclear fusion is always 30 years away? I don't know. Probably not. But I think in the next 5 or 10 years, we're going to learn which organisms are important. We're going to learn how to culture those organisms. And it's already happening. We can culture these organisms in certain cases. Like and we can then really find out exactly in fine detail what works, what doesn't work. We can do a proper study. For instance, we can give capsules with Prevotella in them and see how that works. Then we can control that with just ordinary capsules. We can do really elegant studies. We can see what exactly happens to the microbiome if you try and change it. So that is where the action is. I think
that is super exciting, because those are like designer probiotics that are extremely customizable, that I think will be super interesting in the context of what you were mentioning before, where if you give a fecal or an FMT to somebody who has a really disrupted microbiome, that may not work. So what about individual species and plugging them into the microbiome? Yeah. Time will tell. Now, before we wrap up, Dr. Johan, it's been just I know I could talk to you for another couple hours, but sadly our listeners probably don't have that much time. Are there any absolute sort of contraindications for FMT, so that people don't just say, all right, I'm going to give it a go and have my husband give me his poo and I'm just going to mash it up in a blender and infuse it because I have IBS? I know.
Doing that. You could say that is, the instead of bringing your wife a bunch of flowers, you hand her.
It has to be warm, I think. It has to be fresh poo.
I'm not sure that represents true love or a Valentine's Day gift. However, yes, you've got to be a little bit careful. Our donor screening has to be very tight. There was a recent case where a patient received stool from a donor who had a resistant bacterium, EBSL, in the donor. They didn't test for that. It was in an immunosuppressed patient, and that patient actually died. So I think the important thing is, one, make absolutely sure about your donor. Finding the right donor is very time-consuming and very expensive. Only 10% of the donors that we tested in our study actually qualified. So they were disqualified on various grounds quite often. And most of the donors we test fall down because they have some funny bug in their system or their stools. Some of the bugs are less important than others. We have to test for the extended spectrum resistant organisms. And I certainly wouldn't give any fecal transplant to a patient who's immunosuppressed. Having said that, a lot of the ulcerative colitis patients that did receive fecal transplants were on immunosuppression of some sort. So that's not an absolute rule. And in our study, we didn't see any effects whatsoever. So I think, yes, it is a very safe procedure, but certainly, like with any procedure, there can be side effects. So don't just go rushing into it willy-nilly, and be a little bit careful, certainly.
Wow, Dr. Johan, this has been really illuminating on many levels, and I would love to continue the conversation at some other point. But until then, I think we'll have to leave it there. I want to thank you so much for your time. This is an incredibly exciting field that will probably be completely different in a few years, or maybe not completely different, but we'll have a lot more information on this topic as time goes on. And it sounds like it's rapidly developing, this field, which is really exciting to see, because we need this type of therapy in people's diminishing microbiomes worldwide, really. So it is amazing. So I want to thank you for your time with me. People can find you where? I know we'll have all of your details in the show notes, including links to where I think you have 2 locations, 2 clinics. Did you want to say anything else about your website or?
No, nothing at all. I just enjoyed chatting to you, and I hope you have a wonderful weekend. And it's exciting times. But just as a final point I think I ended one of my slides saying that every complex problem has a solution which is simple, easy, and wrong. So these complex diseases are jolly difficult to treat. Everything we know now in 20 years will be defunct.
That's true.
So let's just know that we don't know.
Let's hope we'll make it until then, right?
Indeed. Thanks.
Okay. Thank you so much for your time.
Have a good weekend. See ya.
Thank you for listening to the SIBO Doctor podcast. We hope you found the information in this episode useful in the treatment of your SIBO patients. Thanks to our sponsors, SIBOtest.com, a breath testing service with easy online ordering, and Quintron, maker of outstanding breath testing equipment. Tune in again for another episode of the SIBO Doctor podcast. Thanks again for listening.